Hello and welcome to the Demonstrating Implementation Excellence stream at the SNOMED CT Expo 2020. I'm Susie Roy, the Customer Relations Lead for the Americas at SNOMED International, and I'll be moderating this session. Please use the Q&A box to type in your questions to the presenters. All questions will be answered at the conclusion of today's session. I'm now very pleased to introduce Fuad Rahman and Rick Meyer of Goldblatt Systems. Today, they'll be presenting Modeling COVID-19 by Proxy, applying SNOMED CT within a virtualized semantic network to deliver a health vigilance platform. Okay, guys, take it away.
Thank you, and thanks to everyone who's attending. My name is Rick Meyer with Goldblatt Systems. We're going to walk you through this study in 4 parts. The first is the goal and the underlying platform. Then Dr. Rahman will walk you through the process, as well as the performance and results, and then we'll conclude with observations, discussions, and hopefully answer a lot of interesting questions. The underlying platform for our artificial intelligence and machine learning solution is the Clinical Semantic Network, or CSN. The CSN, like its name, is a network of semantically built taxonomies and ontologies combining industry standards like SNOMED with our proprietary CSN network. It's purpose-built to capture well-formed and harmonized well-formed data, clinical data to support healthcare decisions, delivery, etc. Next slide. The virtual CSN, or VCSN, is built on that extracted technology that the CSN provides, combined with natural language processing, multiple machine learning models, and its purpose is to synthesize data across structured and unstructured data to allow us to model, predict, and use healthcare data in novel ways. In this case, how do we present and learn from a patient's or a set of patients' journeys through disease and use that information to better use that to predict the future as well as potential severity so that we can prioritize care. We selected influenza because when the pandemic started and we looked at how we might be able to apply our AI technology, we didn't really have COVID-19 data. So we selected influenza, and Dr. Rahman will build out why we made that decision here in a little bit. But we were handicapped a little bit because obviously we didn't have COVID-19 data, but we selected influenza data because it's very similar. The broader premise is, can we use a data-driven machine learning approach to extract data across both unstructured and structured data sources using de-identified data from a health system here in the United States, and use the VCSN as really an underlying platform to support better analytics from enriching the patient data that organizations might already have, but they pulling in data from electronic health records and others that is not terribly useful when it's unstructured. Next slide, please. So in the end, our premise was we believe the VCSN can be an analytics platform that can predict the potential occurrence as well as the potential severity of a disease so that organizations can then stratify patients for risk, help them with the response or health engagement, especially when you look at COVID-19 and its how it attacks vulnerable populations. Next slide.
Thank you, Rick. My name is Fuad Rahman. I'm going to be walking you through the rest of the presentation, and then Rick will come back at the end and conclude. As Rick mentioned before, that when we started this investigation, we didn't have COVID data. So the question in our mind was, is it possible to find a similar disease that shared a lot of the characteristics? And COVID was still emerging at that time. And we sat down with our SME subject matter experts, and we looked at what pre-existing conditions and what other parameters can we use to find other similar diseases? And what we came back with is influenza. And as you can see in this slide, that they share a lot of commonality. They, for example, some of the risk factors are actually shared, like COPD, cardiovascular diseases, diabetes, chronic kidney diseases, right? And if we're looking at the primary condition, both from the comorbidities point of view and from the lab values point of view, it's all makes sense. So we thought we have data that actually related to influenza. Maybe we can use that data to see what happens. So step one is, obviously identify the disease, but step two is, actually build a cohort. Rick mentioned before that we have a database, healthcare database of about 100,000 patients. So we went into that database and build a cohort that matched this pre-existing condition set. And we found about 3,100 patients out of that database, and we actually kind of artificially balanced it. And I hate to use the word artificial, but we did this in a way so that we can get rid of the training bias. Those of us who are actually in the AI side of things, we know that your AI engine can be heavily influenced by what data you use for the training purposes, and we wanted to make sure that that doesn't happen in our case. So we found we basically balanced it half and half. 50% of the patients from that corpus had the same pre-existing conditions, but did not actually ultimately develop influenza, and the other half actually did. So that the machine learning algorithms can do a better job in learning from it. So in step 3, we had to analyze what data are we actually getting. Healthcare data, as you know, is very complicated, and we were able to pull in structured and unstructured data at the same time. And Rick mentioned that before, that we are able to read your patient notes, for example, completely unstructured data. And we have an NLP engine that can actually analyze that, understand it, and extract information out of it. But then that's just a starting point of the investigation. The data that we're pulling out can also be then divided into 3 different parts. Type 1 data that has a time series component to it. For example, your vitals. Every time you go and have a medical encounter, somebody is taking your temperature or your weight, and they all have a time component to it. So I can basically draw a graph out of it, right? Those are time series data. There are other type of data that has a time component to it, but it's a fixed time component. So a particular diagnosis was made on June 15th is a specific example. And there are other things in your healthcare data that does not have a time component, such as elements in your problem list. So in step 3, what we decided to do is, how do we get all this disparate data? I mean, data is coming from different sources. That itself is a complexity. But the data that is coming in is also very different. So how do we actually put them together? So a common practice, obviously, in machine learning and training areas is actually to try to normalize the data. And we have done that. But we found that just normalizing the data is not good enough. So what we went forward is what is called ensemble networks. We built multiple networks, each network specialized in learning from one type of data, this type 1, type 2, type 3 data. And then we put them together and build a larger network out of that, trained another network that's built out of these smaller networks. I want to point out here is that we did not include the time series data. So type 1 data is not included in this investigation. We included type 2 and type 3. So let's now go into what kind of performances we got when we actually did that. So we got about 3,100 patients, as I mentioned before. Half of them were positive data samples, which means they actually developed influenza. And we know that because this has already happened. It's a database of past patients. And we separated the groups into 85-15, meaning that in that ratio, meaning that 85% of the data was used for training purposes, and the rest, 15%, was used for for testing purposes. So the results that I'm going to present are all based on testing purposes. It's a very important thing to point out, because a lot of the cases, especially in machine learning papers and observations, people will, authors will present validation training or training validation results, meaning that how better we can learn, right? In our case, what we are presenting is kind of more old-fashioned, meaning that we learn from the 85% of the data, but the 15% data we tested on, we have never seen before. So it's completely unseen data. And just if you're interested, we extracted 110 different variables from our healthcare records. So it's fairly extensive. And we used different AI techniques, and the one that produced fairly good results is a technique called random forest. And this obviously is not a good forum to talk about that. It's basically a way of arranging your data based on closeness. And then as we see more and more of the data, the closeness metrics gets more and more refined. And that's where the machine learning kicks in. And we build an ensemble network based on that random forest technique. So if you take a look at this data, you'll see that we looked at precision, recall, F1 score, and support scores. Now, why we chose 4 different scores? We chose that because machine learning techniques are notorious for being good at some things and bad at other things. So we wanted to make sure that we test it properly. And please also note that we also are presenting results for the negative samples and positive samples separately. And there's a reason for that. The reason is sometimes AI techniques are very good in picking up positive cases, but are really bad in picking up negative cases. So in one case, it might have a very high, positive error rate, or in other cases, might have very high negative error rate, none of which is good. So we wanted to make sure this is balanced. So if you look at it, the numbers are fairly standard and standardized across different tests. It's around 84 to 86%. And the average F1 score, which is considered to be a very good conservative way of looking at how accurate the system is in identifying influenza, both from the positive and negative cases, is 86%, which is actually, in a complex case like this, is actually very encouraging. And this kind of follows through with what I just said in my when I was talking about the last slide. If you look at this confusion matrix, you see that the true label and the predicted labels across the positive and negative samples are fairly balanced, meaning that there is a 10% error rate in one case and 19% error rate in the other case. It's not like it's 100% and 0%, right? This is actually, again, further validation that our AI engines are able to learn from these systems. And if I want to go more from the clinical context of what it really means is that if I'm applying this to a set of patients for a hospital system, then based on the existing healthcare records, our system should be able to predict with 86% accuracy whether this patient is at a higher risk to develop influenza or at a lower risk of developing influenza. Now, because we did not include time series data, as I mentioned before, we are not able to tell you how the disease will progress. This is actually what we are doing next. This is what we're working on currently. But we can tell you with very high level of confidence that whether these patients will develop influenza or not. And we're hoping that these findings are going to be transferable to COVID cases. As Rick mentioned, when we started working on this particular investigation, we did not have access to COVID data. Now we actually have contracts with 2 organizations, and we are in the process of accessing and getting access to those 2 different independent sources of COVID data. And in the next few months, that's what we're going to be working on. We're going to be actually applying this system to real COVID data and see what actually happens. So let me now walk you through some observations, discussions, and then we'll open it up for questions. So the primary observation that we see here is that we deliberately we chose a fairly simpler metric, whether it's a disease positive or disease negative, and there is a reason for that. The reason is we are dealing with fairly complex set of data coming out of from disparate data sources and coming from structured and unstructured sources. We wanted to make sure that we are able to at least normalize it and build an AI network that can handle these kind of things. And it's always better to crawl and then walk and then run. So that's our motto here. And the other thing that we found out is that and obviously for time purposes, we were not able to show you detailed results of individual performances from these individually trained ensemble networks. But we found that the combination networks actually outperforms any of the individual networks. That actually is a very good sign. That means that we are getting complementary data from the structured sources and unstructured sources. That also means that we're getting complementary data from the type 2 data type, which is time component in it, and the data that does not have a time component in it. These are all good news because that means that we can tap into different parts of a healthcare data from the patients and actually make use of that in building a much better prediction system. The other point that I want to point out is that the next step would be how do we take these same models and predict the progression of it, because that's another very, very big and very important point in addressing a disease such as COVID-19. If we can, for example, say this is what happens, this is what will happen or expected to happen in week 2, week 4, week 16, then that's a completely different way of handling a particular patient group, and that's something that we are expecting that we'll be able to do when we incorporate in our modeling the type 1 data, which is the time series data. So we haven't done that yet. We're hoping to do that in the next few months, and we hope to present that result when that's available. At this point, I would like to hand over control back to Rick, and he's going to talk about. I talked about a very focused, narrowly focused, well-defined problem and how to apply our solution to it. But this has a broader perspective, and Rick can talk a little bit more on that. Rick.
Thanks, Fuad. So to kind of conclude, so what we've figured out or what we've developed is a way to say, take a population and say, who might get influenza, yes or no? And you get a list. Okay, that's step one. But really, when you're talking about how do I engage with a population based on a particular disease, the next question is, well, what order do I go in? How do I prioritize? And that comes into yes, no risk, but then how bad is it going to be? What is the severity going to be? And that's where the time series data, as well as some of our other development projects, are going to help us with. Because in the end, you can have a list of 1,500 people, but you're going to be much more effective if you focus on the ones who are most likely to get the most sick first. Next slide, please. So just to conclude, we're very we feel like we've developed some very promising results by mining patient disease journey data, aggregating structured and unstructured data, using multiple machine learning networks to be able to predict who in a population might get a particular disease. It doesn't have to be influenza. It doesn't have to be COVID. It can be virtually anything. And our ultimate platform is going to be really analytics as a service to support public health vigilance, risk management, and other types of population health initiatives that are really thirsting for us to break down the silos that exist in information in healthcare and not just the silos, but the fact that a lot of information is created in a way that is not terribly usable from an analytics and measurement perspective. With that, thank you for your time, and we'll turn it over for questions.
Thank you, Fuad, and Rick, thank you for that excellent presentation. Some really exciting work going on. So can I please just ask that the attendees just give us one moment while we switch over from our pre-recorded content so that both of our presenters can address all of the questions that you've been submitting live. Please also note that this session will be available on the event platform for the. Okay, thank you as we switch over to live mode. Okay, and go ahead and please write your questions in the Q&A box. It looks like we already have a couple, so go ahead and keep on writing and we will start to answer those now. Okay, so two-part question here from Ivan Boyd. How does the CSN help you in your machine learning, and could you have done it without the CSN? Rick or Fuad?
It's probably a better question for Fuad to answer.
Yes.
Oh, okay.
Can everybody hear me?
Yes. Hi.
Hello.
So we already have one question coming in from Ivan Boyd. It's a two-part question here. How does the CSN help you in your machine learning, and could you have done it without the CSN?
So the CSN is the underlying taxonomy that we have used in the machine learning process. CSN, or Clinical Semantic Network, already is hand curated, and it actually has already created clinical understanding within the taxonomy. That actually helps the machine learning tremendously. So if we did this completely from a natural language point of view, or from a extracting keywords point of view, we would have to derive the relationships from the content, right? But because we had CSN in the as an underlying technology, we already had the relationships mapped, and that, I believe, helped our machine learning in a big way. So to the second question, we could have done it without the CSN, and people have done it in the past. But again, as I just mentioned, at that time you would be relying heavily on extracting information, which means you will need a lot of data to get anything meaningful out of it. Our advantage is that we do not need a lot of data to get something meaningful out of it. And the underlying CSN actually is responsible for that, that specific feature.
Thank you. Another question from John Karak. How do you use the strength of the underlying CSN to better model the disease? Also, I understand you use influenza as a foundation disease. What is your next step?
So I think the first one is kind of already overlapped with the previous question. But so let me jump to the second one. As I mentioned in the presentation itself, that we chose influenza because it has a lot of commonality and a lot of overlap in terms of pre-existing conditions and a lot of other aspects, right? So what we wanted to do is to create a proof of concept that machine learning will work on this kind of problem. And we have actually demonstrated that it actually works really well. So our next step is really looking at the at COVID data, real COVID data from patients. And actually we are right now in the process of acquiring such data from one of our academic partners, and would then see how that works out with our system.
And do you have, this is a question for me, do you have plans on looking at COVID diagnosis as alone, or are you going to break it down to the various symptoms that are found within COVID?
So we are actually trying to, the goal of the first step of this investigation is to look at risk stratification. So we're trying to figure out whether, given a particular set of pre-existing conditions and healthcare markers, are you more likely or less likely to develop COVID, right? So that's actually our first step. So we're looking at it as a holistic problem right now. We, as I also mentioned before, we still haven't looked at that time series data. One of our previous presentations, Monica Jones from NHS was showing that she has started using some of those time series data, and I was very interested in that, and that's something that we actually want to do next.
Yeah, we have. If I can add to that, we have, a powerful platform inside that we can then use to target in different findings and everything else that's in the data, so we can actually measure against outcomes and really see what the patterns that actually emerge from that data. The data can tell us from this model.
Right. And just following up on that, once we have time series data, we should be able to then get into a much more finer representation or modeling. For example, what happens in 1 week after infection, 2 weeks after infection, that kind of stuff, right? Right now, we're unable to do that.
Looks like we have time for 1 or 2 more questions if anyone wanted to squeeze in another question. Looks like we have one from Richard Ellis Gibson. In your study, did you encounter the well-known problem of negation in unstructured clinical text? For example, the patient had no symptoms of diabetes. If so, I would be interested in finding out more about how this was overcome.
Great question.
Yeah.
Great question. Yes, absolutely. We did encounter that, and that's one of the biggest issues in using NLP without really, really curating what actually coming out of it. The way we encountered it is that we actually have a pre-processing module that deals with negation. We spend time understanding it at the language level, so that when it actually is captured as a feature, that negation is taken care of. So yes, this is a great question, because this is often derails any modeling. So we were able to actually handle it because we use that pre-processing module.
Okay, any other questions from the audience? Going once, going twice. Okay, all right. Fuad and Rick, thank you so much for that excellent presentation. Excellent work. And both of our presenters are available on the platform if anyone wanted to ping them with any additional questions. Otherwise, we will see you in the next session. Thank you for joining.
Thank you so much.